Welcome all the participants, attendees of this third day and last day of our 22nd annual general meeting at the CVMN. We are very pleased to have this morning section with you. And I'm Thiago Roca. I'm part of the board of the CVMN. I'm also in charge of the strategic partnerships and business development at Butantan. And I will moderate this section that we will talk about priorities and policies for low and middle income countries with a multilateral view. As Dr. Morena said in the opening session, let the Table Mountain inspire ourselves in this last day, and hopefully next year we will be present in a face-to-face meeting as we did in the last years. So I'm very honored to introduce the speakers, and for the first panel, I'd like to invite Professor Gagandeep Kang from Wellcome Trust Research Lab and Christian Medical College. She'll talk about adapting new technologies, so regulatory challenges and support platforms and LMICs. Professor Kang, the floor is yours. Thank you.
Thank you very much for inviting me to join you here today. I thought I would focus on just a couple of key aspects related to the challenges that we have. And the first relates to regulations and the second to support platforms. Each of these is a very large area, but I think what I'll try to do is highlight key issues, and we could spend a lot more time discussing each of them. Next slide, please. So if we look at what happens when you have new platforms, is that you start with some idea of where you're going, but what is really helpful is to have a clear regulatory pathway. So last year, WHO started with the effort to develop a target product profile in April of 2020, and PDVAC, it is here, also weighed in on this, and the TPP was published in May of 2020. In June of 2020, we had FDA guidance that laid out the kind of information that would be required, which was in many ways platform agnostic, but also referred to some special requirements that might be there as new technologies started to be used. Just as an example, for DCVMNs, the Indian Central Drug Standards Control Organization came up with draft guidance that resembled what had been published before by FDA and by the WHO in September of 2020. Overall, the guidance was similar for safety, for immunogenicity, for efficacy, the kind of data that was going to be required, but also similar approaches to facilitation, to consulting of regulators, and the ability to review data on an ongoing basis. However, China, India, and Russia gave some form of approval even before interim data on efficacy became available for some vaccines. Ultimately, all vaccines have had all the data that has been required. Now, all of those studies depended on either having a placebo arm, or in the case of some of the vectored vaccines, a comparator vaccine was used in the clinical trials. The next slide, please. But we are in a situation today where practically every country has vaccines that have been approved for use, and therefore the input of regulators becomes more and more important. One key question is, can you do placebo-controlled trials? And in many places, regulators are not going to permit that, But there have been some discussions around whether countries with low coverage in Africa that are not likely to receive vaccines in the near future for the bulk of their population, whether they will permit or want to have placebo-controlled trials, which would allow for fast tracking of clinical testing in some platforms. In the absence of placebo-controlled trials, which is much of the rest of the world, what are the possible approaches? And these have been discussed and debated by many people, and the regulators and others have come up with potential strategies. And I won't walk through the details of all of those, but potentially, if you had a highly superior vaccine, which could be compared with a partially effective vaccine, that could be done with a disease endpoint. And this would be done only in locations where the partially effective vaccine is the only option available for the population. We could also look at non-inferiority trials with a disease endpoint, and these would compare a new vaccine to a licensed vaccine, show that the new vaccine is not appreciably worse than the licensed vaccine. This again would require relatively larger studies. The most likely approach, and the one that many regulators are taking now, is thinking through what are the approaches that are based on looking at immune responses. And if we look at immunobridging, it could be that establishing an immune response is likely to predict efficacy on a disease endpoint, and conduct an immunogenicity study to show that the immune response is high, and that can be linked to a confirmatory later efficacy or effectiveness study. Next slide, please. So this is clearly the most likely approach, but what constitutes an appropriate study needs clarification from regulators, and there has been some variation across regulatory authorities. And how can we do this? I think we need to show that there is a mechanism of action with the test vaccine that's similar to the licensed vaccine, that it's possible to demonstrate protection and a relationship between antibody and protection in animal models, have studies that demonstrate the importance of the antibody, and immunogenicity studies that demonstrate antibody levels similar to or greater than a licensed vaccine with high efficacy. Of course, if we have a correlate of protection or even a surrogate correlate of protection, that makes immune studies much, much easier. But who decides what a correlate of protection is? And here is where it becomes very important for regulators to play a role. And there's also a role for the ECBS to think about what needs to be done in terms of using a correlate of protection. So complicated landscape, and we need solutions, and we need them quickly because there are still a lot of vaccines in development. Moving to my next area very quickly. Support platforms in LMICs have had issues. One that many DCVMNs have highlighted is the availability of comparator vaccines if they need to do trials that compare their vaccine with another one. And then there are also the kinds of platforms that are required for preclinical testing, for clinical trials, and for clinical assays. For trial platforms in LMICs, there are several that are part of internationally funded networks. But when you go to new sites, as has been required in LMICs, we've seen that there have been serious issues with recruitment, with follow-up, with outcome assessments, with the ability to handle adverse events. And this speaks to what we need to be doing for the future. Clinical assay platforms with vaccines that require more complicated immune assessments. LMIC rarely have those available, and many DCVMNs have been at the back of a queue waiting for their samples to be evaluated where these platforms exist. So I will stop there and thank you very much for your attention.
Thank you very much, Professor Kang. Really, it's the field the same that we have here in Brazil, and the challenge, the gaps between the regulators. We still have these gaps of understanding, but another way we saw that the pandemic also speeds up the interaction and the harmonization between them. So thank you very much, Professor Kang. Now I'd like to invite Dr. Frank Koblenz, Chair of Department of Global Health at the Amsterdam University. He will talk about highlights from the global roadmap of research and development of tuberculosis vaccines. Professor Dr. Koblenz, the floor is yours. If you can open your camera.
Thank you. I hope you see my screen now. Yes. So thank you very much, Tiago, and thank you very much for the opportunity to present here at this forum the tuberculosis vaccine R&D roadmap. Tuberculosis is a leading cause of illness and mortality. What you see here is the report that was issued just last week by the WHO, which estimates for the year 2020 that there were almost 10 million new tuberculosis cases worldwide, of which 1 million in children, and around 1.5 million deaths. And as you can see here from this map, most of the cases are in South and Southeast Asia and in Sub-Saharan Africa. And tuberculosis is really a problem in low and middle income countries. It's strongly associated with poverty, as you see on the graph on the left-hand side, where the per capita GDP of countries is shown against the tuberculosis incidence with a very clear negative correlation between them. The WHO has set a target to reduce incidence of tuberculosis by 2035 by 90%, but that is very unlikely to be achieved without an effective vaccine. There is a vaccine, as most of you will know. It's BCG. It has been around for around...
Koblenz, just a second. I'm not seeing the presentation mode. I'm not sure if you are in control of the secretariat, but just if you...
Do you see the presentation mode now?
Yes.
Oh,
great.
sorry.
Thank you very much.
Yeah. So I think I'll just continue then. So BCG, the current vaccine, has been around since the 1930s. It's effective against severe TB in children, but not against adult pulmonary tuberculosis and not against transmission. So the WHO has issued, to fill this gap, product profile characteristics actually for 3 types of vaccine. One, the one with the highest priority, a safe, effective and affordable TB vaccine for adolescents and adults. 2, an affordable TB vaccine for neonates and infants that has improved safety and efficacy compared to BCG. And 3, a therapeutic vaccine that would improve tuberculosis treatment outcomes. But that also prompted the need for a global roadmap for research and development for TB vaccines that would list the short and long-term strategic objectives for global TB vaccine development, would provide global stakeholders with key actionable priorities that could help guide directions, and that would focus on affordable vaccines for use in low and middle income countries. And EDCTP, which is the funding mechanism of clinical trials for poverty-related diseases of the European Union, actually picked up this step, if you will, and commissioned us to develop such a roadmap. The roadmap development process was really a process of consultation of a wide range of stakeholders, and you see here below, I'm not going to mention them all, but you see that it is really a very wide range of stakeholder communities or constituencies. So what we did is we had stakeholder interviews followed by a consent workshop with yet other stakeholders, had inputs of all of them on the various drafts. The drafts were then reviewed by PDVAC at WHO and the Scientific Advisory Board of EDCTP, and then the final draft was put out for web consultation and early this year, and then finalized. Essential to this roadmap is the identification of barriers to vaccine R&D, and here you see them grouped in 4 categories. So the key barriers identified to diversifying the pipeline is that approaches followed thus now have been too narrow. with regard to antigens, with regard to platforms, with regard to delivery. Key barriers to accelerating clinical development are lack of validated animal models that predict efficacy in humans, lack of validated laboratory correlates for protection, and need for large-scale phase 3 trials with disease endpoint. Barriers with regard to ensuring public health impact are lack of clear value proposition for countries to introduce a TB vaccine, limited insight in how a TB vaccine for adults would be used and accepted, and similarly poor insight in global and national demand and willingness to pay. And then there were also barriers identified with regard to enabling conditions. These were limited and fragmented funding, siloed science, and limited stakeholder engagement. What you see here is basically the structure of the roadmap. And I will not go in detail here, but I will just highlight the key action lines that we identified. So under the theme of diversifying the pipeline, the main sort of the broad grouping is really in basic and translational science. And what you see here is 4 action lines, and in each, everywhere throughout the roadmap, these action lines have been detailed in very specific actions along with their timing. But the 4 here are mechanisms of and biomarkers of protection, new approaches to vaccine discovery, improved vaccine formulation and delivery, and controlled human infection model. With regard to accelerating clinical development, there were 2 major themes. 1, animal models, 2, clinical trials. With regard to animal models, the action lines are optimized animal models and comparison of vaccine candidates within and across animal models. With regard to clinical trials, the action lines are about improving clinical endpoints, identifying correlates of protection, trial harmonization and design, and trial site capacity. With regard to ensuring public health impact, the main themes are epidemiology and modeling, and research to ensure optimal implementation. The action lines here are for the first to collect country-specific data and do projections, and to do post-licensure studies. With regard to the second, it's research into health system conditions for vaccine introduction and into barriers and enablers of vaccine uptake. And then finally, we identified actions and action lines with regard to these 3 key enabling conditions: funding, open science, and stakeholder engagement. With regard to funding, these action lines, these actions are grouped under attracting new investments in TB vaccine R&D, developing innovative financing mechanisms for TB vaccine R&D, and creating mechanisms that attract investments in early stages of development. For open science, they are promoting timely and open access of data, specimens, and results, and creating a mechanism for coordinating open science. And then finally, for stakeholder engagement, they are creating a supportive environment for TB vaccines, overcoming barriers to delivery and uptake, and promoting TB vaccine and research literacy with the public. And then finally, the steps that have been taken and that are to be taken. We launched the roadmap at the TB Vaccine Forum April this year. The roadmap is now being complemented, meaning that this WHO roadmap that is now being developed on global introduction of TB vaccines is really meant to be complementary to this R&D roadmap. And that roadmap will focus on country value propositions, regulatory strategy, global policy making, and commercialization. Obviously, we are introducing, as we are doing here actually, the roadmap with all relevant stakeholders, and then also will help coordinate their actions. And finally, of course, we need to monitor the roadmap implementation. On the left, you see a link to where you can find it, and otherwise let me know. I can forward it to you. And with that, I would like to acknowledge those who have been closely involved in developing the roadmap, and thank you for your attention.
Dr. Koblenz, thank you very much for your presentation. Although we are almost 2 years living a COVID-19 pandemic, we cannot forget the other disease in a huge impact on public health, and we are pretty aware of tuberculosis issues, especially in low and middle income countries. So thank you very much again. And now I'd like to invite Professor Túlio de Oliveira. I think it will be the only speaker that I pronounce correctly. Professor Túlio is director of the University of KwaZulu-Natal. Although I pronounce correctly Professor Túlio names, the university might apologize. So Professor Túlio, nice to meet you and welcome to this section.
Yeah. Good morning, colleagues. Or afternoon if you are in Asia. It's a great pleasure to present in this conference, and it's also fantastic to see all this development of vaccines in the developing country. So what I would do, I will just take around 7 minutes to kind of present to you what we have done to characterize variants of SARS-CoV-2 in South Africa and Africa. And the main essence of this talk, if it's one take-home message, is that we finally are doing that very well and kind of in real time, both the genotypic and phenotypic characterization. So my name is Túlio de Oliveira. I take position in 2 universities, University of KwaZulu-Natal and Stellenbosch University, and we recently have created the Center for Epidemic Response and Innovation. So just to understand what we did. So we started very early in the pandemic, around like January last year. We got funded by our national government, the Department of Science and Innovation, and the South African Medical Research Council to create a network, what we call the Network of Genomic Surveillance in South Africa. And what we did, we set up 8 different genomics labs, and all of them are always next to this green line, this green block. And this is a national lab in South Africa. So what's the idea is that we could work very close between academic and the National Health Laboratory Service to genotype in real time. What we did now, we managed now to bring some very large genomes, and we are setting up this new entity called the Center for Epidemic Response and Innovation, which we really think that's going to take to the next level genomics in Africa. So what we did, we started very early. The first genomes that we did was end of February last year. And just to ground you here, you have the dates on the x-axis and the proportion of genome. When I have white in relationship, I have like dozens of lineages, so I just simplicity. And around June last year, it started coming the first lineages in South Africa. And so what they got numbers in the classifications. We got 16 lineages, 3 of them dominating the first wave of infection until one new one emerged and then displace all of them and become the most dominant one. And that's what got to know as the beta variant, or what was one of the first variants of concerns to be identified. Very quick, what we did, we worked with some colleagues at the VITS and ICD and at ARI in our building to set up what you call phenotyping kind of real time, both at live virus and also pseudovirus. So what we did is to be able to grow the virus, and then try to evaluate all the different vaccines that were in the market by take convalescent plasma and see how it changed the neutralization of the case, the beta compared with the other variants. And what we saw is reduced neutralization in most of the vaccines, with some of them much higher than others. And then together with a colleague of mine, Professor Salim Abdul Karim, we decided to follow that over time and add also a clinical trial results that we had in South Africa to guide the selection of what would be the most appropriate vaccines to the beta variant. And that's one of the reasons why both Johnson & Johnson and Pfizer, which had a good clinical trial data showing good effectiveness, especially in hospitalization severe, was selected and rolled out in South Africa. We continue doing genomic surveillance, and now just come more recent, what happened, the beta variant dominated like almost a whole year of infections, and then we get introduction of other variants, the alpha variant, until the delta completely take over. So we have this very fast displacement of the beta by the delta. But one that we are currently a little bit worried is still very low level, but it is the C12, It seemed to be quite persistent, that variant. And if you get a look on a phylogenetic tree, and this is what you call a tip-dated phylogenetic tree, here's the date, that emerged from one of the variants or the lineages that dominate our first wave, the C1, with large number of mutations, many of the mutations very similar to the alpha, beta, and gamma. That's the one dominating infection in Brazil. At the moment at low prevalence, yeah, but also with similar characteristics as the beta, lower neutralization of vaccines. And just so we are following that very, very close, yeah. What we decided to do, this technology that we have in South Africa, we decided to really share that widely in Africa, and we end up leading a Pan-African genomics surveillance collaboration with 122 African organizations, yeah, where we just put all our data together. Yeah, initially South Africa was the one that had the largest number of sequence, close to 60%. But what we did is to do a really holistic process that we distributed not only the protocols, but also a big training program. Yeah. And this training program, it involved many steps, involving also a large grant from the Rockefeller Foundation, and in collaboration with the Africa CDC and the WHO Afro, that we're continuously bringing fellows to be trained hands-on the production of the data in the labs, and they live with all the equipment and also the knowledge to set up that. Yeah. What we see in the last 6 months is a massive increase on the number of genomes in Africa, seeing that the program is working quite well. Not only South Africa now, but many African countries getting still close to 1% of genome coverage, and that had increased in the last few months. But more important, with a massive decrease of time, of turnaround time between sampling and production of the genomes, because that's very, very necessary to be able to really try to respond and understand the epidemic in real time. So that's what I have to tell you, yeah, and very happy to say that finally we think that Africa is beginning to use genomic surveillance in real time to identify and then characterize variants at phenotypic level. Yeah, thank you.
We thank you, Professor Tulio, and it's impressive and quite important to the strain surveillance, not only the work that you did, also in South Africa, the work that is in Brazil to discover the gamma strain here, and to keep monitoring the surveillance active even after the status of pandemic, because this is very important to the globe. Thank you, Professor Tulio. And now I'd like to invite Dr. Narendra Arora, Executive Director of Implant Trust International. Dr. Arora.
Thank you very much. Great pleasure, Tiago, to be part of this August gathering. I thought of sharing another dimension, which from a developing country perspective is very important. And as rapidly new vaccines are coming up, and many of these vaccines are developed and then rolled out in our resource-constrained environments, one of the important challenges we are facing is this issue of safety surveillance, vaccine safety surveillance. And I'm not going to make presentation, but I have a couple of points and request for DCVMN to consider how they can partner with national governments to strengthen and to make this more robust than what it is. So we know that with the usual clinical trials, and with Professor Gagandeep has already mentioned the various kind of studies which one is talking about these days. And within these studies, the number of subjects, participants is quite low. And particularly in studies like bridging trial, or even inferiority or non-inferiority or superiority trials, the numbers are few thousands only. And so to get a true insight and dimension is a challenge. And this challenge becomes compounded in the context that many of the resource constrained environments have either non-existing national vaccine AFI or vaccine safety surveillance programs, or if at all, they are pretty weak, and the adverse events are not picked up with the sensitivity which is desired for a new vaccine, and particularly those which are coming out for the first time on new vaccine platforms. So this is a constant issue, and therefore, even though trials are done in many of these countries, later rollout, the adverse event reporting and are almost 1/10 to 1/20th of what one usually sees in high-income countries. And therefore, alternate strategies have to be thought of. Active AFI surveillance is a difficult task. It is resource intensive, and all institutions or the skills and technical skills may not be available. Another important dimension is that when AFIs or AESIs, adverse events of a special interest, as we have been talking about it with many new vaccines coming in, and there is a lot of uncertainty around what kind of events occur. They need a very different approach to investigation, because for the first time, adults are being vaccinated in such large number. So what kind of investigations are required? And then subsequently causality, establishing linkage between vaccine and the event. Temporally, they are all related, but causally, are they related or not? It's a complex and complicated process. It's not simple clinical medicine. And because epidemiology has to be thought through, the product has to be thought through, the local context and the programmatic situations have to be thought to be considered along with the clinical presentation. And these skills are not easily available in many of our countries. Third challenge is about reporting. When the vaccines are rolled out, in general, the whole health staff is busy organizing the delivery systems, managing supply, ensuring or preventing any stockouts and those kind of things. But as far as identifying and then reporting is not given the same importance which it deserves. Another dimension which is very important is that many times the peripheral health worker or the health system feels that these events are their doing. They have committed some mistake. And therefore, there is this fear factor and there is underreporting or no reporting. So how do we move forward? I think the manufacturers, particularly from developing countries, I think can play a very critical role. And as I understand, many times vaccines developed and manufactured by DCVMN members, it takes much longer time for international organizations or regulators of repute and credibility to approve their vaccines, because such information is not available, inadequately available, or whatever is available, its validity has to be is questioned many times. And this is an area which needs special attention, and it's a very critical area for partnership between ministries of health and the vaccine manufacturers, because many ministries of health also do not truly understand or give significance of this dimension. But from a manufacturer's perspective, I think these are very important things, and post-marketing surveillance is a critical component, and all regulators ask for the information which is useful for global recognition of the vaccine. There is this pandemic has thrown up some of the new challenges as far as vaccine safety is concerned. Vaccine trials are done in healthy people. Most of the times you don't take sick, but because of the limited supply, usual stepwise approach for rolling out of the vaccine is not possible. The priority is given to those who are sick and who have comorbidities. Now, this is a reverse process. So while the trials are being done in healthy individuals, but the vaccine to begin with is given in sick individuals. They may have immune deficiencies or they may be having other disorders, which in normal circumstances, they are end of the queue to receive any vaccine. And therefore, monitoring vaccine safety in such group is also very, very important. And again, when, as I have noticed, when these the dossiers are prepared, you go to WHO or the other, they do ask what is your experience with comorbidities or sick individuals. And again, this is in the interest of both the manufacturer as well as the ministries and the national regulators, that they come together and to see how it can be done. Another dimension is that why many times its stepwise approach is not possible. It is fortunate that this pandemic affected adults, but God forbid if there is a next pandemic where children are affected to begin with, and vaccines are to be developed. The usual step is you give it to adults and then slowly go down to the lower age groups. But the process will have to be reversed in that process. And therefore, this vaccine safety is something which needs urgent attention. And this needs building capacities at the national level. This needs partnership, because many of the ministries of health may not realize the importance of this, but from a manufacturer perspective and for community perspective, from scientific perspective, these are very important. So the challenge I am leaving for the network is that how this dimension, this gap can be bridged or at least narrowed. Thank you very much.
Thank you very much for your speech. And indeed, the vaccine safety, it's one of the concerns of the population, and many people assume to not get vaccinated for uncertainty of safety. And so this data should be very well demonstrated, not only from the manufacturers, for the regulators, for the scientific community. So quite important matter to discuss, and a great challenge for our community. Thank you again. And now I'd like to invite and introduce Mrs. Tanya Chernuski. She is a team lead of market information for access at WHO. Mrs. Tanya, it's over to you.
Thank you very much, Mr. Roca, and thanks for having me. So the presentation today was supposedly focusing on the market information for access, which WHO has been leading in collaboration with partners for a few years now. But we had the opportunity to already share some important information from that initiative through the presentation of Kate O'Brien, the director of the immunization department at WHO. And so we've taken the liberty here to really reflect, Chair, on the question that has been asked in terms of the priority and policies for lower income countries, and to really share a multilateral view. So at the beginning of this year, we have come together with a collection of partners in the context of the Immunization Agenda 2030. And we have reflected upon the progress in vaccination in lower income settings over the past 2 decades, as well as what we've learned from COVID. And we've come up with some lessons learned and some thoughts for the future. So I only have 2 slides, and I'll try and be as succinct as possible. And the first slides that we have here is focusing on the progress to date and some shortcomings and experience from COVID. And the next slide will focus on what we propose as a possible change moving forward into the future. So looking at the progress in vaccination in lower income settings over the past 2 decades, I think we can really acknowledge that a lot has been done and has been achieved, and the CVMN has clearly been instrumental in this context. A couple of highlights. One is that we had new vaccines developed for major killers such as pneumonia, diarrhea, and cervical cancer, but also we had vaccines developed for other diseases that affect lower income settings like meningococcal meningitis A, hepatitis E, dengue, malaria, etc. And we have also seen progress in access to these new powerful tools. And this has been very much thanks to global and regional financing and procurement mechanisms such as the Gavi Alliance, UNICEF, the PAHO Revolving Fund, etc. And what these mechanisms have done is really shorten the lag between accessing high income and lower income settings. This said, I'd like to point out a few shortcomings that we've been reflecting upon. They're not on the slides, so I hope you'll be able to follow me. So one of the big shortcomings is that, yes, we have many new powerful tools, but we still lack many for disease like hookworm, Zika, Lassa fever, etc. And also, and I believe my colleague will talk about this more in her talk, but product suitability has been an issue. There have been a series of initiatives developed to try and predict demand for specific product characteristics, but still the certainty of demand is clear only at the end of clinical development processes and for products that don't have a commercial value. This means that we often have suboptimal investments. And second, another big shortcoming is on the manufacturing side. So we've had an expanding supplier base, and really here we'd like to underscore the role of developing country vaccine manufacturers that have come in the past 2 decades, increased competition, increased supply security. Nevertheless, we all know that for specific vaccine, we're still relying on 2-3 products maximum for many of the vaccines that are out there. And also that supply has oftentimes been slower in ramping up than demand has been. The classical example of HPV vaccines, where we've seen very fast growing demand and shortages for several years. And also demand has been unable to react, supply has not been able to react quickly to shocks in demand, so outbreak response or a sudden change in policy and need for more vaccines. So these are just a couple of examples on the shortcomings we've been facing. There are more. Middle-income countries are not being addressed. They are lagging behind, etc. What we have reflected upon is that COVID-19, and here I'm on my 3rd bullet now, has actually addressed some of the shortcomings that I've mentioned, and it's been able to size opportunities. And so what it showed us is that we can actually do more than what we've already done. And let's look at what we learned in COVID-19. One of the big learnings was that if we move away from the sequential and risk-averse paradigm to development and commercialization of products, and we jointly plan clinical development, regulation, manufacturing capacity, this enables us to work in parallel in many parts of the clinical development and commercialization process, and to compress timelines to market, ensuring quality, because we all know that in 11 months from the sequencing of the SARS-CoV-2 genome to the conditional marketing authorization for the first product, and now 17 products in the market, safety has not been compromised. COVID-19 have been submitted for approval with actually larger efficacy data sets than is typically seen in other markets. So how was this possible? Many factors, but two would like to point out. One was the vast public investment, and two was the innovative technologies. I'd like to spend 1 second on the vast public investments. So the pandemic has shown that governments working together with biotech firms, academic institutions, military research units, etc., if fully engaged and putting in place large public contracts and also advanced purchase agreements that guarantee purchase of doses even prior to regulatory approval, can really make a difference in driving fast access to vaccines. So this has been great, and nevertheless, here we are, as we all know, with the example, in the case of COVID-19 vaccines, where we have large parts of the world that are still well below the 10% target coverage for these COVID-19 vaccines, while others have access to doses to even conduct booster programs. And so equity remains a big issue, and it has consequences both on the health side, but also on the socioeconomic side. If we move on to the next slide, I'll conclude the talk by just highlighting what we think or we thought in the context of this discussion of the Immunization Agenda 2030, and love to hear the feedback from the audience, is the need for a paradigm shift here to really ensure sustainable access across the globe. First and foremost, we need early evidence-based informed strategic goals and leadership that can guide, on the one side, the demand, which we've always neglected in our market shaping efforts, and so can help countries pick targets and make planning, pick products, and also the supply side, so the investments from yourselves, so that you can be ready with supply when the time comes. And here WHO has been taking, under the leadership of Dr. Tedros, a more and more proactive role, for instance, with the recent launch of the global strategy to fight COVID-19 and setting a 70% target by mid next year. The second is that we really have seen with COVID, and we want to put this forward for future, that vaccines are a public tool and they need public investment. Governments need to shoulder risk and invest more aggressively than they've done in the past, and even that they've done in the case of COVID-19, to ensure that we can meet the needs of today, but we can also prepare for future emergencies. And the payback is great for vaccines. We've always known this is the most cost-effective intervention. And I think COVID-19 has really taught us what can be lost in economic gains as well. The IMF is estimating $5.3 billion loss if there's no equitable access to vaccines by 2026. So where does this investment need to be focused? There are 4 areas that we'd like to put forward. One is the new vaccine technologies. So we've seen, particularly with the mRNA vaccines, that these bring faster clinical development. It allows for streamlined regulatory, and it allows for agile manufacturing, but also investment de-risking. So WHO is investing here, and this takes me to the second point, to also bring this capacity, these new technologies to be explored for other antigens, but also to be researched, developed, and produced in all regions of the world. We've seen regions that do not have manufacturing capacity clearly penalized in the COVID-19 fight, and this is something that we need to course correct moving forward. So we know, we've been investing in the South African hub for mRNA products. And also we're looking here into understanding the value of manufacturing insurance. So can we have some warm-based manufacturing capacity that in between emergencies is used for research, for stockpiling, for serving markets where capacity is not yet available, and that can be co-owned with the governments and the public sector and leveraged at time of crisis. And then thirdly and fourthly, you've heard this before, this is not new, but it requires more work. One is regulatory harmonization. The DCVMN manufacturers have been particularly penalized by diverging regulatory requirements in different countries. and market transparency. So I was going to talk about the market information for access, but I feel I've bored you quite a bit already in the past years with this, and you know about it now. But basically, we have been able, and really thanks to your engagement, to bring more transparency for about 90% of the global vaccine market. COVID-19 shows we need more of that transparency. We also need more oversight of production. Governments need to have a handle of what is the production capacity, what are the plans for products out of factory, what are the shipment plans, who are the recipients, really have the visibility needed to be able to manage supply, to ensure it's accessed everywhere at fair price, and particularly at time of crisis. And then finally, and I'll stop there, conscious of time, is that we have seen with COVID that despite global and regional mechanisms put in place, we still have to do more to define principles and operational details for collaboration in time of scarcity. We need more diplomacy to ensure we have agreements among governments to enable countries to protect their own citizens, which is very well understood the priority, but also ensure that no country is left behind. And with that, I will stop, and I really want to acknowledge that this is not my own only thinking, but it's shared by many experts, including former manufacturing industry experts and partners, agencies in the immunization arena. Thank you so much.
Thank you, Dr. Chernuski. It's a great presentation. And when we talk about vaccine access, the equity issue should disturb ourselves every day, as we are part of the community of vaccines and also as citizens. So it is something that maybe diplomacy or principles should solve this. So thank you very much to join us today. And now I'd like to invite and introduce Dr. Frederick Christensen, Deputy CEO and Director of People Planning Policy at CEPI. Dr. Christensen, so the floor is yours.
Thank you so much, Mr. Rocha, and thank you for the invite to address all of you. And I would like to start by reflecting on the backdrop of how this pandemic has, clearly called out, as you just said, the enormous failures actually of our existing system, and leading to this grotesque inequity that we see now in the global rollout of vaccines. But it's also welcome to see that there's an increased political focus on building a better system for the future, and it's welcome to hear the discussions going on around the UN, in WHO, and at the G20 on ways to both adequately finance this, govern it, and not least acknowledge the need for a strengthened regional manufacturing capacity. CEPI, as you probably know, has been focused on research and development of vaccines. In this pandemic, we saw a gap that we were able to fill on reserving some manufacturing capacities, buying 1 billion vials, vials for 1 billion doses. So we have sort of progressed into manufacturing, and what I'd like to do is to just say a bit more about what CEPI can do and not do in this area. So am I sharing my screen?
Yes.
Thank you. So in terms of what CEPI is doing, just to be clear, I mean, we will not be investing in brick and mortar vaccine manufacturing capabilities, but what we can do is support a number of important enablers that we have talked about in this meeting, and also not least support innovations to make manufacturing either cheaper, smaller scale, closer to outbreaks. But so far, what the focus has been to look at, starting with identifying problems and gaps. We've performed manufacturing landscape surveys, both in across the African continent and in Latin America and the Caribbean, to identify gaps, but also opportunities. And we have then entered into workshops, both at country level and regional, continental focused, where we review the needs and interests of either countries or regions. And we've, for example, done this in Ethiopia so far, and next week we'll do one with Latin America and the Caribbean region, together with WHO, PAO, and also the government of Mexico and CELAC. So these workshops can sort of both build on the landscape survey, but also then help facilitate and find ways to target investments. In terms of building the case, we are doing a number of epidemiological evidence generation studies on what CEPI priority pathogens. So, for example, in West Africa, we're running a big epidemiological study around the Lassa fever called ENABLE, and this will support how to develop vaccines, but also having clinical trials and prepare for introductions of vaccines in the region. As a scientifically based organization and a neutral organization, hopefully we can really build on that platform to do some global advocacy for the needs for diseases that are endemic for low and middle income countries, and the threats and the needs to be better prepared for future outbreaks, epidemics, and pandemics. And then we are supporting capacity building and infrastructure development, particularly in the clinical trial side. I mentioned the ENABLE study. We will be strengthening that focus and collaborating with other partners in site preparations, and make sure that these sites are also applicable to other pathogens that are of interest to low and middle income countries. We have established a centralized laboratory network and are building that out. So for SARS-CoV-2, this has been established, and there are now 9 laboratories around the globe, 3 in low and middle income countries. And the focus is to develop high quality standards and have access to immunoassays for SARS-CoV-2. But we are looking to expand that in LMICs, not least on the African continent, and also expand it into other diseases. Through the manufacturing task force of COVAX, we have, together with DCVMN and the strong support of DCVMN, also established a marketplace where both the developers or the suppliers of input or the needs for manufacturing vaccines can be matched with manufacturers who see needs for that. And so that's the platform that's up and running and has already provided some good matchmaking. It is open for all DCVMN companies, of course. We're also supporting regulatory harmonization, as we've talked about here. So in support with WHO and other partners in dialogue with AVRF, the EMA, DCGI, and others, we are helping both our partners that we are directly supporting, but also others with a focus on getting to a WHO, EUL, or PQ. And then there's also a strong support for tech transfer, where we, again, support our partners directly, but also together with working with global agencies like the World Trade Organization, WHO, and the G20 countries to advocate for this, but also through the COVAX Manufacturing Task Force, support having feet on the ground in manufacturing sites to really strengthen the tech transfer side. And finally, just to mention, I mean, this is, of course, Gavi's remit, but we are definitely advocating because we see a big need for providing manufacturers with a cohesive support from organizations like CEPI that can provide support for research and development, but also have the pool funding at the other end of the scale through advanced market commitments or advanced purchase agreements for these outbreak and epidemic and pandemic situations. And a tighter alignment between those two mechanisms is going to be important, I believe, for the future. So just let me end by saying that I think, again, CEPI will not invest in manufacturing capacity directly through bricks and mortar, but hopefully we can support a lot. I think this pandemic has shown that science and manufacturing is the way out of a pandemic, but there's still a lot of work to be done to make sure that the science can be enjoyed by all. And let me also acknowledge my colleagues who have supported development of this. We have Barbara Ngiomba on the call, I believe, who's our new partnership senior manager. We have Matthew Dunham, who's been speaking to this meeting as our sustainable manufacturing lead. And not least, we have Dr. Ankur Maitreya, who's just joined for a focus on LMIC engagement. So thank you very much.
Thank you, Dr. Christian, and also we should recognize the brilliant and important work that CEPI is doing in response of this pandemic, and even for diseases that we are still developing new technology and platforms. So congratulations to CEPI team. And now I would like to invite and introduce Dr. Brigitte Giersen, the team lead vaccine platforms and prioritization at WHO. Dr. Brigitte, it's over to you.
Thank you very much. It's a pleasure to be here, a great privilege to have the opportunity to present to you. Before I get going, can I just check that my slides are in the appropriate format?
Yeah, I'm not seeing the presentation mode yet. Now it's okay. Great. Thank you.
Great. Thank you very much. So I'm going to give a few minutes of an update on where we are with a new WHO initiative, a new concept for developing early evidence considerations for vaccine policy. This was previously called Preferred Policy Profiles. We've changed the name, it's now called ECVP. And so I'd like to tell you where we are with it so far. So I'm going to jump in and just give you a little bit of a frame as to why we think we need an ECVP, what is the problem we're trying to solve. Everybody here knows well, there are several steps along the product development to implementation pathway. We've just been hearing about a number of those. And the requirements and the steps to approval are usually pretty straightforward and well understood. But when we're talking about a vaccine that is intended to be deployed in low and middle income countries, there's a series of steps that come after product approval that include a global policy recommendation, WHO pre-qualification, and then financing. And those have a different set of data and evidence requirements than what we would be expecting to be needed for product registration. And obviously, as we've been hearing, the stakeholders evolve as the product advances, and each of these stakeholders have a critical role to play along this continuum, each with their own drivers and priorities depending on the stage of development. And if these stakeholders are not well aligned and coordinated, and if the expectations for data and evidence needed at each step along this continuum are not clear and the evidence is not available, this presents a risk to the manufacturers, and it can jeopardize the investment that is needed to advance products into late stage product development, but also presents a risk that there will be a delay between product approval and actually having the product implemented at the country level. So we're beginning to try to understand what are the questions that will come post-approval, and can we begin to address some of these as part of the product development plan? So do we know what the expectations will be for a policy recommendation, and how can these shape product development at the stage of a product coming into phase 3? What are some of the criteria that will be considered for financing of these vaccines, and how do we build these into thinking about the product development pathway? And as it has already been mentioned, is it clear what the country demand actually is? And are the preferences of those countries being reflected in the products that are actually being developed? So WHO does develop a number of technical products, as we call them, as products come through product development and in the early stages, that include assessment of vaccine value and articulating the potential public health need that a vaccine could offer, the preferred product characteristics that defines product attributes for vaccines, and if they're intended to be used in low and middle income country settings. We develop technology roadmaps to identify the key enablers that need to be in place for vaccines. And developers and vaccine manufacturers, of course, consult with the national regulatory authorities as their vaccines progress towards licensure to get clarity on what is expected in terms of safety, quality, and efficacy. But beyond that, we need this SAGE policy recommendation, pre-qualification and financing. And there is a different framework, if you like, to determine the cost effectiveness and appropriate data that will be needed to inform introduction decisions and financing decisions at the country level. So we have heard very strongly from stakeholders, including members of DCVMN, that there is a clear gap in the evidence anticipated, in understanding the evidence anticipated to facilitate global policy recommendations before phase 3. The preferred product characteristics and roadmaps go some way, but really what we're being asked to provide more evidence on is actually understanding what would likely be the data that would be useful for policy recommendations, and also looking beyond that to understanding what are likely to be important criteria for financing. So this is just a quick assessment on the left here. What are the types of parameters that are developed within preferred product characteristics or target product profiles that WHO develops? And you can see how those measure up against the types of parameters that are considered within a WHO policy recommendation. And then, for example, Gavi's vaccine investment strategy criteria. And clearly these parameters evolve considerably as you move across the product development continuum. So we brought together a number of stakeholders to discuss this gap between preferred product characteristics and the data and mechanisms available for product approval and licensure, and then looking at what is actually going to be needed for policy. We brought together vaccine developers, manufacturers, regulators, policymakers, but also representatives from financing and procurement agencies. Actually, a few of the people on this panel were included. We had a number of roundtable discussions to look at the need for something like the ECVP process. And clearly there was broad consensus from all groups that we need a process and a tool to clarify expectations between regulators and policymakers to improve transparency of what is actually going to be needed. That this will be really important for vaccine developers to inform their strategic planning before phase 3 studies are underway, so that those phase 3 studies can be designed as appropriately as possible to support policy as well as licensure. And that importantly, it'll encourage earlier engagement with national and regional stakeholders to create demand and really create that pull to lay the foundation for a future policy and financing. So this has now been written up and the manuscript has been submitted, so I hope it will be available soon. And we are now in the process of moving forward with developing this ECVP concept. The idea will be to engage regulators and policymakers at the national, regional, and global level, but also to include financing and procurement agencies in those discussions. It's going to be really important for vaccines that address the most urgent medical need where there may be innovative routes to licensure, and these can include, for example, a correlative protection that has been discussed here, but also something like a controlled human infection model. How do we ensure that we still also have the data that is going to be important for some of those broader policy considerations? We need to be very clear that the ECVP is not a policy guideline. It is really seeking to have earlier engagement on these questions, but it doesn't preclude the comprehensive SAGE evidence to recommendation process that's going to be required for any vaccine seeking policy recommendation. We are hoping, though, that it will be a helpful starting point to actually catalyze the formation of SAGE working groups for some of the vaccines that are coming down the pipeline. So just this is my last slide to tell you where we are now. We have drafted a generic framework that is based very broadly on the SAGE evidence to recommendation framework. We've incorporated the input that we had from the consultation that I just mentioned, and we now have a fantastic advisory group that's been put together. We're going to kick this off next week to do two things. We're going to finalize the draft generic ECVP framework so that it can be available for other vaccines. And then we're going to develop the first one using TB vaccines for adolescents and adults as the first test case. And this complements very nicely with the presentation that Dr. Koblenz just gave a few moments ago. Once this is drafted, the TB ECVP will be posted online. We very much welcome broad public consultation, and particularly from the DCVM members. And then we hope to actually present this towards the end of next year and open up the framework for broader vaccines coming down the pipeline. That's it from me. Thank you very much.
Dr. Gibson, thank you very much for joining us in this section. It was a great pleasure. And for the sake of time, I'd like to introduce our last speaker, Dr. Jikri Dong from WHO, Unit Head of Local Production and Assisted Unit. Nice to meet you again, Dr. Dong, and the floor is yours.
Thank you, Chair. I would like to thank the organizers for your kind invitation. And it's my pleasure to be here. Can I have my slide? Thank you.
Thank you.
Next slide, please. So the local production of medicines, vaccines, and other health technologies has been a subject of discussion in WHO since 1970s. Since 2008, there has been a new focus on local production as a means of promoting innovation, building capacity, and improving access. This year, a landmark resolution, WHA 74.6, on strengthening local production of medicines and other health technologies to improve access was adopted at the 74th World Health Assembly, with more than 100 member states co-sponsoring this resolution. You can see how important of local production as a means to improve access that will be recognized by the member states. In this resolution, member states requested the WHO to explore a global platform to promote technology transfer and local production. Next slide, please. So to echo this request, WHO announced a new WHO initiative. It's called the World Local Production Forum, Enhancing Access to Medicines and Other Health Technologies, or WLPF in short. It is a regular forum for the global community of foremost government leaders, industries, technology experts, UN agencies, international organizations, and other stakeholders to stimulate high-level dialogue and action, promote collaboration, and shape the direction globally in promoting local production to improve timely, equitable access. The local production and assistance unit in the regulation and pre-qualification department Access Medicine and Health Product Division of WHO, is the secretariat of this forum. Next slide, please. So the first WLPF convened virtually this June after the World Health Assembly. And there was high-level participation by delegates from more than 100 member states and other stakeholders in the global community in the discourse on key issues related to local production, such as how to build a business ecosystem, how to strengthen a regulatory system, licensing, technology transfer, innovation, and financing. I just named a few. Next slide, please. So I would also like to take this opportunity to thank all the member states and our partners for their support in organizing and participating in the forum, including our chair today. Thank you. Next slide, please. There was a session dedicated to look at the vaccines at different angles for COVID-19 and beyond, such as the vaccine ecosystem, innovation, and the technology transfer. There were some key messages from this session. For instance, diversification in technology, product, and location is important for pandemic preparedness and sustainability. The hub and the spoke model could deliver high impact to diversification with efficiency. As we all know, vaccine production needs a diverse range of know-how and skills. For instance, the technical capacity to absorb technology is proportional to R&D know-how and skill. In addition, the National Regulatory Authority also needs staff with the right capacity and expertise to ensure oversight of quality, safety, and efficacy. Therefore, workforce development is absolutely critical in vaccine manufacturing. Sustainability of our production capacity beyond COVID-19 needs to be considered. Innovative technology could play a role in sustainability, for example, by providing production flexibility across vaccines and biologicals. So during these discussions, collaborations and partnerships were repeatedly highlighted. Next slide, please. So 3 actionable recommendations resulted from the first World Local Production Forum, such as the one in the middle on your screen, to explore a mechanism to stimulate industry engagement in World Local Production Forum, and provide a platform to strengthen collaborations and harness opportunities for diffusion of technologies to low and middle income countries. As we all know, manufacturers are a significant actor in promoting local production. At the end of the forum, the Netherlands announced they will be the hosting country for the next World Local Production Forum. Please join us. So next slide. Should you wish to have more information on WHO local production and assistant work, and also on World Local Production Forum, please visit our website. With that, I thank you all for your attention. Thank you, Xia. Over to you.
Thank you very much, Dr. Dong. Indeed, it's a great initiative at WHO. It was my honor to be part of the World Forum. And local production will be the tool that we have to respond to the next pandemics. And I hope the CVMN and the manufacturers can contribute in the next forum. So I'd like also to thank all the speakers that we had today. We are close to the next section, but I'd like to invite all the participants of the CVMN annual meeting to join the chat too, and also to visit the exhibition hall and our sponsors there. And hope we have a great and last day. Thank you very much.